when not speaking to prevent audio interference. My name is Jimena Garcia, and I'm the Governor's Senior Advisor for Vaccine Equity. And I'm going to be leading this discussion today together with my colleagues from KUMC and KDHE. And one disclaimer, I'm at a vaccine conference and I'm sitting in a hotel room that I was supposed to check out of like right now at noon, but there's no late checkout and I need a quiet spot. So if somebody bangs on the door, I might have to step away. So anyway, I'm going to start with a quick review of the agenda, if you don't mind putting it up. Okay, just a sec. I always lose my notes there. Okay, so we're going to start as usual with a moment for introductions from new members. And then we're going to have Jamie Gable, a senior epidemiologist at KDHE, and she's going to walk us through the most recent COVID vaccine data. And then I'm going to talk just really briefly about the new bivalent COVID boosters that are available. And from there, we're going to hear from Dr. Kali Akers, who will review what we have covered over the past few months and then talk about where we are heading going forward. And then finally, the second half, I'm going to share some information about Paxlovid, the antiviral treatment for COVID, and some concerns that have been brought to our attention by community members in terms of access to Paxlovid. And after that, we're going to move into breakout groups to talk about strategies that communities might develop to advocate for themselves with their doctors so that they can be prescribed Paxlovid if they get COVID. And then at the end, we'll come back together and hear about the different strategies the groups have come up with. So if you don't mind, Vicki, take down the slides and let's start with quick intros. So if you're attending this meeting for the first time, we'd love to hear from you. Please tell us your name, your organization, and your GLOW, which is 5 words or fewer describing something you're passionate about. If you're a regular member of COVID, please put your name and organization in the chat. And I'm going to start, I hope she's on here, start the introductions by passing the floor to Carolina Lorenzo, who is the new interim director of KLAC. She's taking over for Aude. So if you're on, Carolina, do you want to introduce yourself and tell us a little about yourself? Let's see if she's on here. Maybe she's not on.
I'm not sure that I see her.
Okay. So maybe I'll open the floor to anybody who's new who would like to introduce themselves.
Hi, this is Lucia. I think I'm new for this meeting. I am,
Wonderful.
right? Yes.
Yes.
This is Lucia with United Healthcare. And Dr. Garcia, what was the third point?
Your GLOW. So 5 words or less about something that you're so passionate about that you could talk for an hour about it if somebody asked you.
I can talk about social determinants of health forever.
Perfect. Thank you, Lucia.
Right. Thank you.
Good afternoon. So sorry, go ahead.
Oh, sorry. My name is Nicole Smith. I am here on behalf of the Kansas Black Farmers Association. We run a mobile clinic for COVID vaccines, and I am passionate about prevention, teaching our communities prevention in order to keep them healthy.
Thank you, Nicole. Welcome. Tori, over to you.
So I'm Tori Gleason. I'm here in Lawrence, Kansas. I'm at LMH Health. I'm a chiropractor in KU Medical Student School of Medicine at MPH Epidemiology. What I'm passionate about is the LGBTQ community in the state of Kansas and the 92,000 people that are represented there.
Thank you. Welcome. Is there anybody else that's new today? Okay, well, thank you. Oh, Dr. Donna Pudi, do you want to introduce yourself?
Can you hear me?
Yes.
Okay. Medicaid medical director to the KDHE, and this is my, I think I just did 3 months this week. And in terms of my glow, I'm going to throw it to psychological safety, creating environments with psychological safety.
Thank you so much. And thank you for joining us. Okay, I think that's everybody. Or Berta, do you want to introduce yourself?
Hello, everyone. Berta Mendoza. I work for K-State Research and Extension based in the Southwest area of the state. And I'm also a member of KLEC. I think I was present last meeting, but
Okay.
It's good to see all of you.
Thank you. Thank you for joining again. Okay, so I am going to pass the floor now to Jamie Gable, Senior Epidemiologist at KDHE, to share the new vaccination data with all of us and walk us through.
Thanks, Dr. Garcia. Courtney, do you have the slide? Thank you. So as you can see, we have a construction zone occurring right now, and that is due to the new bivalent booster doses. I think, and please somebody correct me if I'm wrong, a lot of what this group is trying to get at is who is up to date with their COVID vaccine. And so if we just look at regular boosters, at this point, that's not going to tell us that information due to the changes in definitions. So when we see this next month, this will have bivalent booster information in it. That's not quite ready. Since this is taken from the 7th, a lot of places in Kansas did not have that booster available at that time in their location. So we'll see that next month. I did not include regular boosters this month just because at this point they are not particularly relevant to describing who is up to date with COVID. So we see that the tender age is still low at only 5.6% with one dose and 1% with the completed full series. If you'd please go to the next slide. This is just a little bit of a description on our plans for the construction area. So we're planning on doing a similar thing that we did with the regular boosters, where we said the eligible population that have received their bivalent booster dose. If there is a preference to have it as just the total population rather than who is eligible, please let me know. We can look at it that way instead. I'm really open to either idea. For the sake of simplicity for what we had looked at before, we thought it might be easier understanding it to just continue as we had before, but change it to bivalent. But if there's a preference to do it a different way, let me know and we can do that. If you next slide, please. So we see that overall the under 18 is going to be increasing at a much higher rate than over 18. We're seeing the highest increases in the white population and the Asian population. And we see both Hispanic and Latino and non-Hispanic Latino are increasing at the same rate right now. Next slide, please. So we know that we are still having issues with our American Indian Alaska Native group. I believe I contacted somebody from our smaller outbreak group. So I think they were having sort of a busy time, so we couldn't meet until later to discuss more population information to try to get a better number for this. So this is still ongoing as an issue. But to just take a look at it, our KDHE WebIZ has it at 8.2%. And the reason why KDHE's is so low is for a couple of reasons. One, because we don't get all federally administered vaccine information into WebIZ. It's not required for them to submit. Some do, some don't. And when those come in, a lot of people who may be categorized as American Indian Alaska Native also would self-identify as other races as well. So they get put into a multiracial group, which is highly inflated due to this issue with both American Indian Alaska Native and other races. And IHS, we do look at what they have reported, but the issue with that number is that it's reported that they got an administration through IHS. It does not necessarily mean that they are American Indian or Alaska Native to have received that dose. But CDC, they say national coverage for all age groups for American Indian and Alaska Native is at 71.7%. Next slide, please. So when we look at 18 plus vaccination, it really, the increase is extremely low. Right now, we're seeing the highest increase in the Black population and the Hispanic and Latino population. Next slide, please. So the same information that we talked about for American Indian Alaska Native populations for under 18, those also exist for over 18. So KSY/Z has their coverage at 24%. We know that this is lower than what it really is. And for IHS, it's at 64.4%. And as I said earlier, it's hard to determine exactly how accurate the IHS information is for telling us this due to the issues that I talked about before. I believe that is my last slide. Please, in the chat or out loud, if you have questions, let me know. If I don't have the answer right away, I'll certainly get back to you.
Thank you so much, Jamie. That was a great presentation. Any questions for Jamie?
Yeah, Vicky, I am curious. This is John Carney. We seem to kind of have this recurring issue around lack of data or lack of verifiable data. I'm wondering if maybe there's, as we progress through this, if the report would focus more on kind of improvements in collection, as opposed to constantly reporting that we're, 30% different than what other. I'm just wondering if the staff spends a lot of time putting this stuff together, and I know they have to have the data, and that's important, but for us, we look at it and think, well, for me, it's kind of a shrug. It's like, well, obviously the data is not right, or we aren't collecting the data. But is there a kind of a task or something that we could be doing to help support better collection of the data so it does mirror what we think it ought to be? I don't know. How can we be more helpful, I guess, in this?
Yeah, that's a good question. And Dr. Garcia did kind of see that as a conversation that we had. When was that? Maybe it was in August or at the end of July, to kind of have a smaller group that had a more vested interest and more information for this particular population, to kind of go through some of those issues. And I did reach out to a couple of the people that were part of that conversation who had some ideas, but at that point, they weren't at a place where they were able to continue it at that time. But I think that it will probably be picked up soon. It's hard to tell you that we've made progress in it, because the data we get in is the data we get in. We can't make data magically appear that isn't there being submitted to us.
John, thank you for that question. Yes, it's something that gives me a lot of angst that we don't have better data, and I hate that we have to share it like this. And it is, we do have a group of people from the Indigenous community and people that work in the Indigenous community that has met one time, and it is our goal to try to have better data. I honestly don't think it's going to be quick, because it involves kind of a lot of steps, and also there's trust issues with data. And but anyway, we are working on it, and I really, really appreciate your feedback. And I would love feedback from anybody about what can be helpful for you all. And so thanks for that. And we really are working on it.
I saw a comment from Ian, and I was wondering to get a little bit more information on what you mean about that, because I'm just not quite sure what it means, and I want to get more information.
Yeah. Afternoon, everyone. Familiar faces, new faces. I'm trying to say it without sounding too techie. If you
Go
have,
ahead.
Sorry.
No, I say go ahead.
Yeah, if you have access to the data, you can engineer it and take certain pieces of it and put it into the right categories and then republish it. It's actually not difficult, but you would need access to either the data collection tool, or you would have to have the the permissions to pull the data into either Python or Excel, whatever you use, and then put those responses into the correct categories.
Yeah, so I think maybe there's a little bit of confusion on how the data is collected. This is all submitted. This is all the vaccines that were administered, and it goes into Kansas WebIZ every time it's administered. And it is cleaned. It absolutely is cleaned. The problem is that we do not like to change the way people identify their own race. So if they identify themselves with more than one race, we don't change it to just the one race. So if somebody were to identify as American Indian and also put that they were Black, we would consider them multiracial.
Okay, sorry, yeah, I thought that through the cleaning process, someone put it that way. They did it themselves. Okay. I
Yes,
understand
yes,
the
it's,
issue now.
it's self-identified race, and we don't like to change how someone self-identifies.
Yeah, that's understood.
So if that's true, then should we be reporting different data then? I mean, if we're not going to be able to scrub it or whatever you got to do to kind of make it fit the categories that are there, what's the benefit of reporting it? Why don't we report it the way you get it? I mean, I don't know that I maybe this is something you have to do for CDC or something. But for us, it seems that all we ever look at is really, big differences in numbers, and it's hard for me to say what ought we to be thinking about, other than the fact that the data are difficult to collect or the data are difficult to report. That's all I kind of see in this, is that it's not easy. But I'd be fine if you said, okay, this is how people are reporting their data, and maybe you can't do that. Maybe you have to do it on a CDC model or something.
So yeah, and I understand both your question and your frustration. I guess part of the issue with reporting every single possible race combination available is that we don't have a denominator to describe that in many cases, or at least we don't have an accurate one. And you could say the same about our multiracial population. We find that we have a lot of people both on the COVID case side and on the vaccine administered side, a lot of people who are self-identifying as multiracial that from a census perspective are not identified as multiracial. So you could say overall, maybe we have a denominator issue, but I don't know that there is a particularly inclusive way to fix it that works for all categories. But I'm certainly open to ideas and continuing the discussion.
Yeah, thank you, Jamie, for that. And thank you, John, for the great questions. I think if we could put this on a parking lot to come back to, I think that would help us move through the agenda. But I think we're highlighting a really important issue. I know that there is the smaller group that's being convened specifically around data for Indigenous groups that is working on this, but it sounds like coming back to the topic of how do we present the data with fidelity to how people have identified themselves and has utility for this group is something to be thoughtful of. So we're going to put that on a parking lot and come back to that and possibly do some reach outs between meetings to address that. Does that sound okay to everybody?
Yes, thank you, Vicki, for that.
Yeah, so I'm going to kick it to Dr. Garcia to wrap up. I think she was going to add some more information to add on to what Jamie indicated about boosters, as that is a change in context before we move on.
That sounds great. Yeah, I wanted to spend a minute just talking about the new boosters. I think I might, oh no, I don't have a slide for that. Okay, so do you mind taking the slides down? Okay. Oh, okay. Sorry, I'm getting all off track. Okay, I am at this point going to pass the floor over to Vicki, who's going to kind of wrap up where we've been and then sort of point us in the direction of where we're going. So over to you, Vicki.
Thank you, Dr. Garcia. I'm trying to make the slides work for me as as well as talk at the same time, which apparently I am powerless to do. So thanks everybody. So we, as you might recall, we have used this graphic to describe sort of where we are at in the journey for COVID over this year. As you likely recall, we spent February through June exploring barriers to vaccination and really did some deep dives in breakout groups to think about barriers that were being encountered, how communications and other strategies could be supportive of efforts to expand access and uptake of vaccination. That really led to a lot of conversation about trust and the role of medical racism and other factors that contributed to distrust in medicine as well as government. So we spent really July and August kind of unpacking that as racism and discrimination are social determinants of health. So that fit really well into the planned unit for exploring social determinants of health. We are, as well as the broader context of public health in this pandemic. So we're kind of stepping further into that and exploring public health in the pandemic context and really thinking about how, particularly today, I think Dr. Garcia will be teeing up some discussion about how do we provide supports and communications that support advocacy of the people that we serve, as well as our own advocacy for advancing access to treatments like Paxlovid. And that is all within the context of thinking about public health in the pandemic context. We'll continue that theme for the next few months through November and be looking to wrap up the year in December, which it feels like we'll be here before we know it. But we wanted to just go back to that big picture and contextualize where we've been and where we're going, and looking forward to that great conversation that will happen today and in the next few meetings. So with that, Dr. Garcia, I think I'll hand it back to you to talk a little bit and preview some of the content regarding Paxlovid and how it relates to communications that might be distributed.
Perfect. Thank you so much for that, Vicki. So before we get to the Paxlovid, I just wanted to spend 1 minute talking about the new boosters that are available. So there is a new bivalent COVID booster that's available. It's in clinics, pharmacies, and at doctors' offices. So this booster is adapted to provide protection from the original COVID strains and additionally also the Omicron BA4 and 5 variants, which are the predominant strains that are circulating now. So it's specific and hopefully, we know for sure it prevents serious disease from COVID and including these Omicron strains. Just 1 minute about recommendations. So luckily this time around, the guidance is pretty simple. So if you have not received a booster in the last 2 months and you are 12 years old or over, get the new booster as soon as possible. And it looks like it's going to likely be a yearly vaccine similar to the flu vaccine. So that was all I was going to talk about the boosters. Does anybody have any specific questions about those? Yay, Christina, you got yours.
I have a question, Dr. Jimena. Does this
Of
take
course.
into account an infection? So if they've been infected in the last couple months, or is there a waiting period for that?
There's not an official waiting period, but I have heard some people say that if you've had it in the last 3 months, that you might wait until you're at that 3-month mark. But it's not so important. So it's like if you can either get it now or you're not going to be able to get it, just get it, even if you've had it. So thank you for that question.
Thank you.
Okay, great. Well, so if you don't mind, Vicki, maybe put the slides back up. I wanted to spend the next few minutes bringing up some concerns that we have heard from community members about access to Paxlovid. So Paxlovid is the oral antiviral pill that's indicated for people who test positive for COVID and who are at risk for serious illness. It's a new medication, but antivirals are not new at all. And the most common antiviral that you might have heard of is Tamiflu, and that's prescribed for the flu. So it was brought to our attention by some folks in the community that some people are having a hard time getting a prescription for Paxlovid. So we've heard a variety of things. For example, people were told by their doctors they weren't sick enough, that it doesn't work. And even somebody was prescribed an antibiotic and a steroid as treatment instead of the treatment that's indicated for COVID, which is Paxlovid. So my thought for today was for us to break into work groups to discuss whether our communities might be interested in developing an informational brochure. So sort of like arming people with facts about what the indications are for Paxlovid, and then think through what context would resonate with the communities we work in or are a part of. So this way people can make a COVID plan ahead of time. And if they get COVID and want to take Paxlovid, they can have the information to advocate for the medication with their doctors, or even advocate ahead of time with their doctors so that they know they can get a prescription when they, if they get COVID. So next slide, please. I wanted to just take 2 minutes to walk through the list of medical indications for Paxlovid. So it's a relatively inclusive list, and I just highlighted the conditions that are pretty common. So just to run through chronic lung disease, including asthma, COPD, diabetes types 1 and 2, heart conditions, including hypertension, cerebrovascular disease, mental health conditions, including depression, being overweight is an indication, or obese and a BMI over 25, or being physically inactive, also pregnancy, and also smoking, either currently or a former smoker. So these are all pretty common things. So I think it's important for people to be aware that these are considered factors that predispose you to severe COVID illness. Next slide. I also wanted to point out that a person's risk of severe illness increases with each underlying medical condition that they have. And additionally, people are more susceptible to underlying medical conditions based on their living and or work conditions, access to health care. So people over 65 years old, people from racial and or ethnic minority groups, and people with disabilities. So this is a pretty wide net, and people should know these things when advocating for themselves for treatment with COVID. And then finally, it's important to begin treatment as soon as possible, and certainly within 5 days of symptom onset. And I wanted to just touch on Paxlovid is indicated even when the initial symptoms are mild. My mother-in-law was given a prescription, but told to wait and see if her symptoms worsened before she took it, which is not what the recommendations are. So I just wanted to give that little bit of background. And now with Vicky's help, we're going to move into our breakout groups to discuss what we're hearing from community members about access to Paxlovid, and if there's work that people think we can do to create information for groups. So I think you're being invited to join a group, and we'll talk on the other side.
So, please do accept the invitation. We'll try to